Hi, everyone, and thanks to Lauren and the Divisional Registrars for this wonderful opportunity. I must admit, I feel like I'm in a radio studio, a little bit nervous at the moment, but in any case, taking care of the really sick patient with COVID-19 can be extremely challenging. And what we're going to focus on is that the patient in respiratory failure. And what we're going to go through is that we're going to take the very difficult and changing pathophysiology and try to make it as simple as possible. And by making it as simple as possible, we're going to translate it into effective clinical care. Now, there's one thing I do want to assure you of. Nothing actually has changed. You just carry on doing what you're doing. You just got to keep on doing it really well. So, things are changing daily, and it can be often intimidating, and especially the issues around PPE. And that is not what we're going to touch on today. And I know that's often a burning issue amongst many of you. Now, information is arriving at you at the speed of a fire hose. And basically, the issue is that you need to stay as calm as possible. And this is really important because no plan survives first contact with an enemy. And what matters actually is that how quickly you're able to adapt when things change. So let's have a look at how we're going to make sense of the chaos. And again, an important principle is to keep it simple. So we're going to start with a case. And your case is a patient who is 35 years old. He's active for all of his ADLs. He's had flu-like symptoms over the last sort of 8 to 9 days, and he comes to you with, he comes to you in respiratory distress, and he's got a SATs of 80% on room air. You do his chest X-ray, and his chest X-ray is very typical of what a patient with COVID-19 would have on a chest X-ray. And if you look at this X-ray, you can appreciate that there's a sort of a bilateral ground glass appearance. There's basolateral involvement. Okay. And so let's have a look at your first thing. And the first thing that you need to do is when you're approaching a sick patient is safety. All right? Gloves, gowns, and goggles. And that hasn't changed. All right? And that is the fundamental issue to take cognizance of. The next important thing to remember is various treatment modalities have various aerosol dispersion distances. Now, if you have a look at this graph over here, the one that has the least dispersion is a non-rebreather mask. And even putting a patient on a Venturi or simple masks allows for dispersion up to about 40 to 50 centimeters. Now, that's not to say that you cannot use a Venturi or simple mask. We've got to be practical in these scenarios. And if you are using it, you just add a face mask on top of it. Okay. So I know that the amount of pathophysiology is inversely proportional to the interest in the lecture. So what you're going to try and do is we're going to try and make this as simple as possible. All right. So COVID-19 is a multi-phase disease, and that's really important to understand. Okay. And patients can present in each of the different phases. And stage 1 is often referred to as the early phase or the viral response phase. And in this phase, patients tend to have a dry cough, They might have some rhinorrhea, they may have some nasal symptoms, and that may resolve or may progress. As it moves along, it moves on into the pulmonary phase, and that pulmonary phase is divided into the phase where the patients are hypoxic or they're not. And lastly, it can move on into a phase such as the hyperinflammatory phase. And in that phase, that's basically often sometimes referred to as the cytokine storm phase. All right. And that's a very, very dangerous phase for patients to present in. So we'll try and break that down a bit more simply. All right. The other aspect is that it's a very humbling disease. And to sort out who needs intensive care and who doesn't need intensive care is really difficult. And the difficulty lies in the heterogeneity and in the presentation. Okay. Patients sometimes can be hypoxic, but their work of breathing might not be there. And that's often been referred to as the silent hypoxia phenotype. And what we're going to do is we're going to try and explain that. Okay. The next important thing, and I'm reiterating the point, is that patients can be okay for several days and then they can abruptly deteriorate. So you have to have your guard up when dealing with these patients. All right. So again, reiterating the point, mild phase, then you get your pulmonary phase or your respiratory phase where they can be hypoxic or not hypoxic. They can deteriorate and they can move into the massive hyperacute phase with your cytokine, into your cytokine storm phase. Now, there's many reasons why this happens, okay? And one of the reasons is that the early phase of the respiratory failure affects the pulmonary vasculature. So what basically happens is that there is hyperperfusion to areas of the lung that are gasless. All right, and that perfusion, to break it down simply, is just Jamakar. Okay. There's also a procoagulative state, and in that procoagulative state, there's microvascular pulmonary thrombosis. But the lung compliance is generally good, so the lung is able to stretch. It's not typically ARDS, but the later phase can be ARDS. Okay. The last part is a massive cytokine storm phase, and that's been linked to a very similar disease process known as hemophagocytic lymphohistiocytosis with an overlap with DIC. Okay. And that basically patients tend to have a fever, they may or may not have splenomegaly, and they often have a bicytopenia. So let's have a look at ARDS and to see whether COVID-19 really fits into the ARDS. The issue is around the timing, okay? And as you know, COVID-19 tends to have a pretty long course, and it's not less than 1 week. It tends to last for up to about 14 days, so that doesn't really fit, okay? And the other issue is that it doesn't account for the phenotype where the patient is hypoxic with sets of 80 or 70, but looks extremely well. So, but where it does fit is that it does fit into the second phenotype, and we'll come and explain that now, known as the H phenotype. So it's not typically full ARDS. So just to reiterate the point, it may not be the same as ARDS. All right. So let's go more into the pathophysiology. So let's look at the hypoxemia. And the hypoxemia generally can happen due to three main processes. The first one, we are referred to it as it being DMACAR, is basically the dysregulation of the pulmonary perfusion. Okay. And over there, what happens is that the lung has a low elastance, low VQ mismatch, low liquidability, and a limited PEEP response, but an extremely high compliance, right? Now the compliance just basically means that the lung is basically able to stretch. Okay. The next part is that the L phenotype can either stay as an L phenotype, or the patient can progress into the phenotype H. And in that phenotype H, the lung often is filled with pulmonary edema. Now, the easiest way to remember it, for example, is that if you have a look at that, you have an alveolus. On the top and at the bottom, you have a capillary. And now what happens in ARDS, that alveolus becomes filled with alveolar edema. There's all this macrophages and neutrophils around it. There's a big hyaline membrane, right? And that basically can't, it becomes filled, and so it can't really stretch, right? The other part is about that capillary at the bottom. That capillary starts developing microthrombi. So this H type of patient has a high lung elastance. So high lung elastance just means that we're going to need a higher pressure to elicit a volume change. It's highly recruitable. That means we're going to need a higher PEEP, and we're going to have a higher PEEP response, and there's massive shunts. Okay. So the way to remember it is that you have your L phenotype, and in the L phenotype, everything is low, and the lung mass is also low. And the phenotype H is also got a high lung mass because of the dense consolidation that is there. All right, so if you look at pictures A and B, A would be similar to someone who's got phenotype L. You can see there's still the bilateral ground glass appearance, the basolateral infiltrates, and you can see B is your type H phenotype. And there you can see the lung is definitely much more dense with bilateral ground glass appearance, and you can see that this dense consolidation with air bronchograms coming through. If you had to do a CT scan on the patient, you can appreciate the two types. Okay, so you can see your type L, and what you can appreciate over here in your type L is that you can see that you have your ground glass appearances in your lateral aspect, right? Just below your pleura, and you can see your type H, where you get your basal consolidation, your bilateral basal consolidations. And you can clearly see just by looking at the images, you can see that if you had to weigh the two lungs, your type H would definitely be heavier. All right. Carrying on with the pathophysiology, all right. So how would you know? How would you know who is going to be a type L or type H? The type H patient tends to be that patient who's working really hard and is in severe respiratory distress. The type L patient is that patient who's calm and comfortable, it's not working hard, but the SATS is low, right? And how you'd know is that you just do a test with oxygen. So if you give the patient oxygen and their SATs rise to whatever level you're willing to accept, for example, around about 94, 95, right? And if you're getting a good response, then you don't have a high shunt fraction. But if you get a poor response, then you know, having a look at this graph, that you've got a high shunt fraction, and you've got a large VQ mismatch. And in that patient that doesn't respond to oxygen, you may need additional pressure. And that's where your ventilation comes in. So what I'm saying is that when you see your patient, do your initial clinical assessment, having a look at your patient as you normally would always do. And then decide, give a trial of oxygen. If oxygen works, SATs come up, patient looks like it's likely a type L. You give oxygen, things are not working out, sats are not rising, patient's looking in trouble, you're going to need pressure. And that's where you're going to end up with your type H type of patient. Okay. Right. A little more pathophysiology, I promise. A few more slides. So let's look at the respiratory drive. Now, the respiratory drive is influenced by various factors. And the first factor, which is very important to understand, is the metabolic drive. And these patients sometimes can be extremely toxic. They can be febrile with a massive inflammatory response, and this causes oxygen consumption and a high demand. All right? Now, when patients are hypoxic, they're going to breathe deeper and they're going to breathe faster, and there'll be changes in this tidal volume. These changes in the tidal volume change your pressures within your esophagus and within your lung, and this adds to the stress and the strain. How you fix hypoxemia? You need to give the patient oxygen. By giving oxygen, you improve the VQ mismatch. Next, the next factor that influences the respiratory drive is your pulmonary edema. And that's what happens in your type H patient. Okay, and they have this work of breathing, which is often described as an elastic work of breathing, and they have a high respiratory rate. Those patients, you're not going to win with just oxygen, and you need to give them mechanical support. And possibly the reason that explains this silent or happy hypoxic is this neurotropism due to the virus, and it's to do with the midbrain and the cardiorespiratory center and some dysregulation within that. And that possibly can explain some of the features such as the anosmia. And that influences the patient's perception of the work of breathing. So as you can see, it's quite a complex pathophysiology. Right. So what happens is that there's impaired gas exchange and lung elastance. So that's impaired. Right. With that being impaired, there's an increase in the respiratory drive. With the increase in the respiratory drive, there's change in the esophageal pressure, an increase in change in your lung pressures, your transpulmonary pressures. There's then a capillary leak, and then there's lung edema, and that cycle just continues and continues and continues. Okay. So having a look at the disease course and what happens. So this patient can either present hyperacute to you. So this patient can present in severe respiratory distress. They can be hypoxemic and breathless, and they're going to need an immediate intubation. And just remember taking it back. PPE first, before you guys jump in. This patient who presents can improve or get worse. Or you may get another type of patient that comes in with severe hypoxia but moderate work of breathing. And that patient, you may get away with something like a nasal prong plus a rebreather and putting the patient into the prone position. And I'll explain to you the value of the awake proning now. But just be wary that if that patient fits the type L phenotype, the patient can have a biphasic response. And afterwards, at about 5 to 7 days, there can be this hyperinflammatory response, a cytokine storm phase. You get raised CRPs, raised ferritin, and the patient can deteriorate. Something very similar to where Boris Johnson is now, Boris Johnson. So let's just hope he doesn't go into the cytokine storm phase. All right. So again, it comes back to the clinical picture, right? Tachypnea and hypoxemia necessarily do not seem to be an indication. If you are worried that the patient is getting tired, that's something else. Okay? But mental status and increasing dyspnea or your CO2 rising or falling may be better indicators of who to intubate. I'm going to add a third one. That sick feeling that you have that, listen, this thing is not working out, is also possibly a reason to intubate. Okay. Okay. It's a clinical indication. Is there something that can maybe help you? Yeah, you can try something known as the ROX index, but this was done on patients on high flow nasal oxygen. But it possibly is something that can help you. You can have a look at your sats over your FiO2, and then put that over your respiratory rate. And a higher ROX index is associated with a lower risk of intubation, but this doesn't replace your clinical reasoning. All right, so let's go back now. Now that you guys understand the basic and the advanced pathophysiology, what are you going to do about it? What you're going to do is that you're going to start your patient on nasal cannula oxygen with a face mask at about 5 to 6 liters a minute and see if that works. All right, if that doesn't, you're going to escalate to a non-rebreather mask. All right. Non-rebreather mask does have less aerosol dispersion, but if you want to be extra safe, you can add a face mask as well. Over here at the moment, for us in our South African settings, we're not going to be going down the high flow nasal cannula route unless the patient is in an isolated room with negative pressure suction, or down the CPAP route. All right, so if they're failing the non-rebreather, the patient's getting tired and not looking well, we're likely going to proceed straight then afterwards to endotracheal intubation if the patient is a candidate. All right, so this is the mask that I'm referring to. Okay. So how are you going to pre-oxygenate? And that often is a question, because we're not going to be able to bag the patient, because if we bag the patient, there's going to be a high risk that there's going to be aerosolization when we do bag. So one of the ways to bag is one of the ways to provide the patient with pre-oxygenation is via apneic oxygenation. So if your nasal prong and rebreather on its own allows you a higher sats, that's great. If you're not able to, you can attach a PEEP valve to a bag valve mask. You can appreciate the PEEP valve on the top at about 11 o'clock, right? And that just holding the PEEP valve on top of the patient while the patient is breathing spontaneously will allow you to increase your saturation. Right. So let's have a look now at awake proning, and is this something that we can actually do? And the answer is yes. And the reason that it works, so if you have a look at it, the majority of the lung is actually posteriorly. And what happens is that when you move the patient from the supine to the prone position, what you're doing is that you're decreasing the VQ mismatch. And you're decreasing the VQ mismatch. And the other thing that you're doing is that you're decreasing lung compression. All right. And you're reducing the amount of atelectasis that there is. All right. There's a whole lot of other things that it does, including reducing lung compression, lung perfusion, and allows you for better recruitment. This can be done with the patient being awake, or can be done with the patient on the ventilator. Okay. You just get a more homogeneous area of ventilation, as you can appreciate from the two diagrams. Right. So at this point, I think, you would be happier with the patient with lower sats and focus on their work of breathing and mental status as triggers for intubation. If they do not have a high, if they're comfortable with a low sats, add them onto nasal prong, rebreather, and turn them around. The treatment there is oxygen. The treatment there is not pressure. If they are distressed or they're deteriorating from this, the treatment then is oxygen and pressure. Okay, I hope that's Understood. Okay, so who you're going to intubate is a long discussion. But basically, if you just have a look at it, right, I can ask yourself a few questions. Is the pathology reversible in its current state? If the patient comes in and the patient's gasping and the patient looks like the patient's currently dying, then the patient must get palliative care. And we must do the most humane thing possible. In the patient's current state, is the patient able to recover? Have a look at the frailty scale. You would have seen that in the new guidelines. Okay. What are the comorbidities, and is there any end organ dysfunction? And lastly, gestalt based on years of experience. So, for example, if you have a patient who's 60 years old, known with SLE, on chronic steroids, with interstitial lung disease, even though that patient's not going to have a good outcome, right? And no real scoring system is going to be able to tell you that. But that would be something that you'll be able to pick up based on years of experience. Okay. So let's have a look at an algorithm of the management of respiratory failure. And what I've done here is we just divided it into assessing the severity, helping you trying to determine the phenotypes, and telling you what to monitor when you have decided that you're moving down the H phenotype. And lastly, are there any other strategies for failure and escalation? So that patient comes in with respiratory failure. The patient's got this bilateral infiltrates on chest X-ray. That patient must get oxygen. All right. If that patient improves, that's fantastic. If that patient does not improve with oxygen therapy, then the decision is that we're going to intubate. But remember, with ARDS, the PEEP is a very high PEEP, can be almost 20 and above. With these patients with COVID-19, the PEEP generally does not need to be so high. And that PEEP is advised to be starting at about 8 centimeters of water. Okay. So you put the patient on volume control ventilation at about 8 ml per kilo, PEEP of 8, and you chase your end-tidal CO2 to about 4.5. And remember, when you put a patient on a ventilator, you always have targets. You have targets for your SATs, PO2, PCO2, and you want to monitor your plateau pressure. So generally, we try to keep our plateau pressures less than about 30. The next thing to monitor is your driving pressure. Okay, so your driving pressure is your plateau pressure minus your PEEP. Now, if you have someone with a high driving pressure, that means you're going to need pressure. That means your tidal volume must reduce, because that means you've probably got more of the L type, the ARDS type. And then you go to the traditional ARDS type where you have a lower tidal volume. Okay. Next, we will carry on with neuromuscular blockade. And the next thing to check is that you want to check your lung compliance on the ventilator. Okay. Now your lung compliance, the formula is, it will come in the slides later, it's your tidal volume over your plateau pressure minus PEEP. Right? You get static and you get dynamic compliance, but if you can remember that formula, it will be great. Now, basically, your compliance just basically means, is your lung able to stretch? And if your lung is able to stretch, that's fantastic. Then all you do is that you just carry on your current strategy and you turn your patient prone. If you're really struggling, so your driving pressure is massively high, your lung is not compliant, then you're possibly going to need a rescue therapy such as APRV. The scope of this talk is not to cover APRV, but we can cover that at the next point. If APRV is not working, then the next phase is And if your hypoxemia is refractory, then it's to discuss the patient to see if the patient might be an ECMO candidate. Just to put you at ease about APRV, right? All that APRV is that if the spontaneous breathing patient, all you're doing in APRV is that you're giving a certain pressure over a longer time. That means you're allowing, so the pressure is over 5 seconds and it comes back down. 5 seconds, come back down. And that you're allowing more lung to be recruited. Okay. All right. So let's take that algorithm and let's break it down. So a lot of this lecture has the things being repeated and repeated and repeated. And the point is, it's just so that, those concepts can be assimilated. The first point again, put the patient onto oxygen. After you put the patient onto oxygen, have a look at their work of breathing. If their work of breathing is high, we're in a bit of trouble. If their work of breathing is low and they're tolerating our nasal prongs and our rebreather, we need to monitor them, all right? And we need to know that they're either going to get better or they can deteriorate. All right. Now, I just want to talk a little bit about high flow nasal oxygen, non-invasive ventilation, CPAP. Okay. And basically, those kind of variables depend a lot on the following factors. The one is infection control, and you know that those are not great for infection control, and especially in our environments and surroundings where we don't have single rooms for our patients in negative pressure. The next thing is to have a look at, what support does the patient need? I mean, if they've got a high work of breathing, non-invasive ventilation is not really going to help there. It may help temporarily, but that patient needs to be extremely well monitored. They have a high failure rate, and often when patients are hypoxic, they pull out stuff. So now, if they are non-invasive ventilation, and they become restless, and they start pulling off their devices, that's just a mess. Okay. The duration, right? This is not a disease that gets better in 1 or 2 days. It's a disease that takes a long time to get better, up to about 2 weeks. Resources are a big constraint. So ICU beds, staffing, ventilators. Remember, high flow nasal cannula, if you're going to put the patient on 60 liters per minute, that's a lot of oxygen. We don't have that amount of oxygen. So besides for that aspect, de novo respiratory failure has a greater risk of NIV, non-invasive ventilatory failure just on its own. Patients tend to have a higher rate of intubation after being on NIV. They tend to generate higher tidal volumes, and this higher tidal volumes may lead to ventilator-induced lung injury and may move them faster from a type L phenotype to a type H phenotype. And when this intubation is done, it may often delay. It may often be delayed and may be too late. And it's also has been shown to have a higher ICU mortality. Okay. All right. So let's move on to the next aspect of the flow diagram, in that we've put the patient onto oxygen. We've decided now that we're going to intubate the patient. Remember again, check the driving pressure. Driving pressure is your plateau pressure minus PEEP. And the thing to remember, if your driving pressure is very, very high, then you're going to have to reduce your tidal volume in order to not get ventilator-induced lung injury. Okay. Right. The next thing to check again is your compliance. The formula for compliance is tidal volume over plateau pressure minus PEEP. Is your lung able to stretch? Okay. Then you can, and then lastly, you're going to, if your lung is able to stretch, then you most likely are dealing with the phenotype L, where those patients have the low elastance, and they are prone responsive. If you're not winning and you've got your patient having to switch over to APRV, then you know you're dealing with likely a H phenotype. And just to remind you, the H phenotype is that lung with the heavy consolidation, high elastance, but they are PEEP responsive. And proning does help. So proning helps both types of patients. Okay, it's really good for changing the VQ mismatch, for improving the VQ mismatch. Okay, and lastly, if you're in in your refractory phase, your X-rays look like that, and ECMO might not necessarily be a thing that we go to in South Africa, but it has been used overseas with varying rates of success. But the mortality rate once patients are on a ventilator can be as high as 50%. All right, so just to summarize, you must remember to recognize the hyperacute disease. And that hyperacute disease, the patient needs immediate intubation after you put on your PPE. And just remember that patients are also at high risk of cardiovascular events, such as myocarditis. All right. If it is applicable within your surroundings and circumstances, and if you have an isolation room and there's no resource limitation and you've got helmet CPAP, then that patient can be tried onto non-invasive ventilation. But just be wary about the high failure rate and be wary about ventilator-induced lung injury and be wary about the biphasic course. It's quite important to early to type and differentiate between the L and the H phenotype, and you can do that clinically. Although it has been described to be they have a high sensitivity with a CT scan, but you can do it clinically. And the L phenotype, just to remind you, is those patients who have a preserved compliance, but their pulmonary perfusion is dysregulated. So what that basically means is that they get hyperperfused to areas of lungs, to the area of lung that's gasless. So by moving the patient prone, you change the VQ mismatch, and you're able to perfuse areas of the lung that are not affected. All right. And just be wary that the type L phenotype is not ARDS. When they do move into the type H phenotype, it may well be a patient similar to ARDS, but just be wary that high PEEP may be very harmful. Besides for it causing ventilator-induced lung injury, it may also drop your hemodynamics. Okay, so that's it for the academic side. I just wanted to put a small note about COVID-19 and just to give you a little bit of encouragement that, you know, it's a very difficult time for a lot of us, and the key is our approach to COVID-19, and whether we want to be in a fear zone, whether we want to be in a learning zone, or whether we want to be in a growth zone. And the way to extend our circle is to be in a growth zone. All right. And that is basically, you know, thinking about others, helping others, and spreading hope. All right. Thank you very much.
Okay, geez, I think I speak on behalf of everyone when I would like to say thank you very much to Saad for producing this talk. It's clearly a wealth of information and effort that has gone into this. And we actually only asked Saad to do it on Friday, so he spent the entire weekend presenting this beautiful talk. What we're going to do now is we're going to take some questions. You can obviously hear the echo because I'm sitting in the same room as Saad, so just bear with us for a few minutes. If we're going to turn off the presentation now, we've got lined up for the next, as Luke said before, we do have an entire talk on intubating the COVID patient. There's going to be an entire talk as well on ventilator management. So we can possibly stave those questions and maybe just go into what Saad has presented, the actual clinical management, pathophysiology, and that kind of thing. I am going to hand over to Saad now, put my mic off, and we'll put off this presentation, and then you can fire away with your questions. If you have a question, please just turn on your camera so we know who's asking it and what you wanted to say. Cool.
Hi, Saad. Can I ask a question? It's Emily here.
Hi, Emily.
I'm just trying to turn on this camera. There we go. I just wanted to ask if COVID is not similar to ARDS, are we able to still use the ARDS criteria to determine who needs to be tubed? Because obviously there are also those phenotype L patients who are happily hypoxemic. Do we then decide based on the ARDS, probably the PF ratio, that they actually need to be tubed, or do we actually still base it on clinical circumstances?
No, so you combine it together with the Berlin criteria, but you still do it on your clinical circumstances. So even though they are extremely hypoxic, I wouldn't advise just jumping ahead and intubating the patient.
Okay.
So the clinical will trump any biochemical value that you have. But obviously, that, for example, they may deteriorate at some point. So obviously, my advice there here's a disclaimer that you just need to watch and see what happens. But I wouldn't, if you have a PF ratio if you have a PF ratio that tends to be on your severe aspect, you're likely to be a H type. But if your PF ratio tends to be a mild to a moderate, you're likely to be a L type. So using that, you can see where you're fitting into it. Okay.
And just another question in terms of that, would you wait till they are confused, pulling out their drip, going down that route before you tube? Or would you say that maybe the one gas, the PF ratio was worse and was terrible and now it's worsening, even though the patient looks happily hypoxemic? Would you wait till they're on the brink of needing a tube to tube them? Or would you say, because we know the progression of the disease, to rather tube early?
No, so I won't go along the line of tubing early. So the thing is, it's very difficult if you don't have that patient in front of you. The one thing I do know for sure is that you don't want to be doing a last minute intubation. So that has to be the patient in front of you. And I think there you have to take your clinical discretion. And if you think that your patient, and the big sign that I would look for is a slight restlessness. The minute they start to be slightly delirious and start pulling things, or that will be a big time that I'll say, okay, listen, now we're not waiting. But if you're able to have a coherent conversation with the patient, then I'll be happy to wait. And have a look at their work of breathing. Their work of breathing would be very important. If their work of breathing is extremely heavy, with lots of accessory muscle use, nasal flaring, sternocleidomastoid muscle use, then I would intubate. I think it's.
Can I have a quick question, Saad?
Yeah.
Firstly, thanks for the talk. I think that is probably the talk all of us have been waiting for with this. So thank you very much. Just quickly, so if your type L is mostly a vascular problem, and it's isn't that going to give you a VQ mismatch if you've sort of essentially got an issue of blood supply to non-oxygenated areas? So if it's a vascular problem, I don't entirely understand why then after that you say that there's it's not really a VQ mismatch and then they're very oxygen responsive. Don't entirely get it.
No. It is a VQ mismatch problem, and you improve the VQ mismatch by giving the patient more oxygen and then by turning them prone.
Okay, all right.
Yeah.
And then just the last question. So do we need to, once we've intubated, do we need to keep them paralyzed? Because obviously to measure your plateau pressure, you need a paralyzed patient. So then would you top them up with rock and keep them paralyzed, or would you just do it immediately after we've tube them in the rock before it wears off, quickly get a P flat, and then take it from there?
Yes.
What would you do?
No. So my advice is to paralyze the patient and keep them as flat as possible. Yeah. And once they're in a controlled ICU environment, then afterwards they can stop paralyzing them. So my advice is to rather we'll use necessarily rock for intubation, and then afterwards keep the patient paralyzed.
Okay, cool. Thanks very much.
And also the other reason for that, besides if the patient, the other reason is that you actually don't want that tube to come out at any point.
Okay. Yeah, sure.
Okay.
Okay, cool. Thanks, Ed. Thanks.
Okay. All right.
Guys, is there nobody else? Does have any questions? Okay, I think we're going to call that. We will make this video available afterwards for those who want to review it, because it's actually quite great content. And then for those who weren't here with us at this point in time, I just once again like to thank Saad on behalf of everyone, and good luck.
Bye.